Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome, everybody. We're here with special conference coverage at Rapids 2026 in Fort Lauderdale. I'm Eileen Cheever. I'm honored to be here with Stephanie Simmerman, a fabulous nurse practitioner, and we're going to talk through some of the amazing lectures she gave here at the symposium. Welcome.
Thank you. Appreciate you having me. It's an honor.
So we were so thrilled to see you on the podium talking about the abstracts that were submitted for our symposium. So that first one that you had talked about was regarding dupilumab in kids, regarding their growth and issues surrounding bone demineralization. What were the key takeaways from that study?
I think, there's clinically and then there's how that speaks to the poster, and that we all know that there's dangers of undertreating kids with moderate to severe atopic dermatitis. And one of them is, right, that kind of failure to thrive, if you will, of limiting their growth. And what we've been able to do with these posters and these abstracts are to see that when you actually check serum biomarkers for patients. And this particular one was children 2 to 5, and they were looking at total ALP. And what they found was that for patients being treated with dupilumab at the 16-week mark, that total ALP increased. And when they looked at how that correlated with their growth charts, there was a significant improvement over just the 16-week period in their growth and development. A point that they did note in their conclusion on this was that the boys increased in growth more than girls, but that this particular poster hadn't addressed that. But that could be the next knowledge gap and for something for us to explore.
A next point to really take our study in our direction. And also really important information for us as clinicians to know about, whether it's
Absolutely.
sharing this information with pediatricians, getting this information out to parents, and really helping them feel confident when they make a decision to initiate something like a biologic.
Yeah, because there's so much fear for a parent of, it's a chronic disease, for these patients, but it's such a fear for the patient's family, much more than the patient of like getting that injection started, right? And we do know that it does sting a bit. And so it's a hard injection sometimes to give to kids. But when you see them improve and you see their growth improve and you see all the other things that, go so far beyond this poster with a medication, that's non-immune suppressing, it's completely impactful.
Absolutely. So shifting to our adult patients, there was another poster that you presented regarding maintaining minimal disease control in adults that have moderate to severe disease. And what does maybe, that dosing schedule look like? Because it is correlated to a lot of the questions we get from our patients. I'm doing better. I'm doing well. What's the expectation for my dosing long term with XYZ drug? But this looks at dupilumab. Tell us
Yeah.
about that.
And I like the way that you frame it because I often feel like my patients, as soon as they're better, their first question is, when can I stop? you know? And so you're having that discussion, right? Real world of, okay, what can this look like? And so what this particular poster looked at and was really, really helpful is that it was so real world where they treated patients on dupilumab and then they randomized them. And then they said, okay, we're going to keep some on the standard dose of every 2 weeks. Some we're going to see how you do at 4 weeks, 8 weeks, and then placebo. And what they found is that the patients that were on our typical like 2 to 4 week doses, they still achieved a high level of the disease control, right? And so the impact on their quality of life was significant.
Fantastic. And that's just something to kind of keep in the back of our mind when we're talking about patients about what that next step might be.
And if I can, I feel like I've seen this real world too, and that's what these are supposed to be, right? This is supposed to be about clinical research translating into clinical impact. And so I've seen this with my patients where it's like once we're stable, and everybody has a different window. Some people are 6 to 12 months of stability before we tinker, and some people will say 2 years. Everybody has a preference. But what the data showed here is that, there was such an improvement in quality of life and that you could space it out a little bit. And that's okay because so many patients do better and feel better with, I want to do the least amount I have to still have quality of life, to still feel good, to not itch, right? To still, right, have all of those things that's the whole point of why we're doing all of this.
They want that freedom.
Yes.
And a lot of conversation regarding itch at Rapids here.
Mhm.
And there was a poster that you covered talking about the impact of chronic itch, whether it be on patients' overall enjoyment of life and activity or pain. What can you tell us about the impact of itch in those type of patient-reported type of outcomes.
Yeah, this is a great poster out of UT Health in San Antonio. And what they looked at is they stratified patients. And these were adult patients, and they looked at the patients. And basically, what they wanted to do was assess pain severity. And they looked at it in patients who had been suffering from chronic itch for less than 12 weeks, or 13 to 54 weeks, or greater than 54 weeks. And what they found that itch pain severity was similar despite how long that itch had been present. So I thought that was kind of interesting. But then they broke it down even further and they said, okay, now we're going to look at how long you've had the itch and how much that's interfered with enjoyment of activity. And what they found is that the longer someone had the itch, the more it interfered with their activities. And to me, as a clinician and as a patient with eczema, it makes sense. In the beginning, if I've only been itchy for a few months, but I'm probably working with someone towards something, I'm still optimistic and it's not really that burdensome. But the longer I have this chronic itch, the longer I'm not feeling well, the more I kind of become removed from the activities that are important to me, the more impact that has. And so it's important. And I think a lot of times, sometimes our patients come to us, especially those of us who do a lot of the injections and systemics, they have been itchy for a long time. And they've probably been undertreated with some triamcinolone, the 1 pound jar or something. So it's just kind of understanding that also about. I had a patient tell me, she was a server, and I'm deviating a bit here, but it really resonated with me. And so she was a server in a restaurant, and she would seat people, and they'd be a little bit cranky. But then by the time like they had their appetizer, and she'd come back to get the dinner meal, it was like she finally met them because they were hungry and they had been waiting to eat and they were frustrated. And how many times we walk in the room with these patients who have been itching, for maybe a year or two by the time they finally find us. And then you're giving them, right, the sample, or you're getting them on drug pretty quickly. And then they come back for their 1 month, 2 month, few week follow up, and they're a completely different person. Right. And they're hugging you and their eyes are glazing. And you're just like, holy smokes, this is so high reward what we do. And I'll talk about this a little bit later because I we're going to segue a little bit, but it's so impactful because we get such instant gratification in our occupation.
And giving those patients hope,
Yeah.
and really,
Oh,
even with verbal or nonverbal
absolutely.
communication cues, that you're in this with them and that
Mhm.
you're there to really try to get them better. And I think this session just wrapped up so wonderfully. Let's talk about the hair care and healthcare study. We actually had the author of the poster, though we didn't know it, in the audience. So tell
In
us
the
about that.
audience. So I was presenting some of this data, and it was basically she had done a study, and I had no idea that she was there. But she had done a community intervention where she sought out to see if she could make an impact on African American patients who were seen in barbershops or in cosmetology schools. So Miriam conducted a study where she did an educational training with barbers and cosmetology students, and she did a pre-survey to assess their baseline knowledge of some of these scarring alopecia conditions, because we know that scarring alopecia conditions are diagnosed late. And when they're diagnosed late, there's nothing that we can do, right? So early intervention is key. And so if we do a community outreach, does this make an impact by doing like a PowerPoint training? And so she did a pre-test, the training, and a post-test. And then she actually had a QR code where people could assess, essentially, she could assess referrals and follow up. And so it was really impactful because what she found is that it did make a difference in early recognition. And it made a difference in terms of, I think, us all hearing this in that room and having her to speak in greater detail than her poster about how she designed it and how she got started, because she did this independently, right? This was not an industry sponsored poster. And just asking her even how she was able to figure out how to put together a poster. So not only was it, wow, like you're so accomplished. And I need to point out, as I was trying to present her poster, in somewhat of a fashion as she could as the expert to it, she was in the audience and smiling at me. And I kept thinking, wow, she's just really happy about this. So when we found out halfway through that she was the actual author, I was like, okay, this makes complete sense.
And she's not even a practicing nurse practitioner at this time.
Yeah.
She's just already got this
Yeah.
motivation and drive to be thinking about these gaps in care. And it was just so inspiring.
And I think to take it a step further is that it was beautiful because it also, what the discussion that we had as the group, and that's what I shared with the group in the beginning. I want us at the end to have a discussion. And so what she ended up doing to be able to say, like, people were like, this could be something that could be used in HS. This could be something, the community outreach that could be done. And everybody just starts thinking in these different ways. And it's like when you have leadership in the room and some industry in the room, gosh, it just takes it that next step further of this goes so far beyond just this. right? Particular condition. And yet what an impact it did make for that patient population.
It was really wonderful. Wonderful. And hey, while we have you, I think we should shift to your other lecture that you presented here at Rapids regarding operational efficiency.
Yes.
How can we just continue to improve and strive for efficiencies when we're seeing our patients, we're talking about initiating systemic therapies? What do you think is the biggest bottleneck that many of us are facing in our clinics when it comes to getting patients from decision to actually starting
Mhm.
systemic therapy? What's your opinion about those bottlenecks?
We have a whole hour-long presentation this afternoon regarding that, right? Because there's quite a few, and it's over the years, because the struggle is different based upon you working in private practice and private equity, and how far are you into practice, that's 0 to 5 years, right? And then beyond. And I think of this as, my goodness, I have been practicing for 13 years. These drugs have come at me pretty quickly, but they've trickled in. Imagine being a new grad and all of these things are at you, and you're like, "Where do I start?" So we're not taught the operational efficiency in school, and so I think a big part of it is imparting the knowledge. It's sharing, like telling people what your struggles have been, what your pinch points, where you've excelled, and I think that sharing that knowledge in a digestible way with people is really how we make the most impact with it, because you follow up and you see a lot of the similar people at conferences, right? And sharing and connecting and being able to say, like, "Here's my number. At the end of this, if you have questions, just reach out to me." Because you wanna help, you really do, and I think that it's having genuine people who love to teach and want to see the patient, that spectrum. We wanna see more people dive into the inflammatory disease,
And when
area.
you connect with these people at conferences, what are they saying they're struggling with? What's their pinch point? What are they asking you for advice to get around? Anything in particular?
Yeah, I think there's a couple things. Number one is, like, how do you get started in terms of, like, how do you have the patient discussion? And I talk about that, how this is chapter 1, this is chapter 2. We're not doing all of this in terms of talking access, the medications, your disease state in one visit. And so it's how do I space it out? And I lay that out in this presentation. And then also it's, what do I do if my collaborative, I don't call them supervising, if my collaborative physician doesn't do this? Who do I reach out to if I don't know what to do? And that's scary, right? Especially when you're new. I mean, there's times where I fortunately have a consultant that I can reach out to who originally trained me and stayed on, and I'm blessed. Laura Taylor and I have him, Dr. Kamisa, because not everybody does, and I don't take that for granted. But I think the more we interact with people and the more they view us as, I can't call myself a disease state expert. I don't know. I'm too humble, right?
Sure.
But
Sure.
it knowing that they can reach out to us also, I think gives them the confidence to say, "Jump in." And especially when you teach them about the utilization of our medical science liaisons, right? Who they are, how you reach them. I hear more and more about people being able to, and it's not always even a phone call. It's, I need to refer someone into you for a second opinion, and I'm happy to take it back over. I just want to make sure you think I'm on the right track. And I realize you can't always do this on the phone or do this on lunch break. And so it's how you set up those relationships.
It can be a phone a friend, but it can be really just sending them
Yeah.
and then asking them to
Yep.
give the opinion and
And
then
then get
sending
them
them
back
back.
to me. I'm not dumping on you,
That's right.
right?
That's right.
Because I've been called the rash queen, and I'm like, not a title I'm looking for.
Not wearing that crown. And you had mentioned earlier in what you just said with the new patient with these visits sometimes being this is chapter 1, this is chapter 2. New patient visits can sometimes be a pinch point, whether it is from
Mhm.
an efficiency point of view,
Yeah.
your medical assistants, your nurses really doing an intake and making sure they're setting the stage for a really effective but efficient visit. Maybe what's one thing that you hope a new patient, maybe even regardless of what they're seeing you for, really takes away? Are you just really saying, I hope at the end of that visit I just established that trust that we're going to be on the same page as each other. And this is a relationship we can build on. What are you hoping they take away from that first visit with you?
Yeah, I want them to walk away feeling empowered. I want them to walk away knowing what the plan of care, maybe we haven't selected the exact drug you're going on because this is just talking about it and me ordering your blood work, but I've set the expectations for what's to come next. And that I have an entire armamentarium of medications that we're going to be able to select from that are clean and safe and effective. And so it's really just an empowering visit of, we've heard your story, we see your disease state, but we see you as the patient, and this is where we're going to be able to take you.
And I think that's smart because if you can accomplish that, that might make things even next week or 2 days down the line a little easier from an efficiency point of view because you've covered that. So maybe you're not having a lot of callbacks or follow-up questions or patients inboxing you with things that maybe you didn't cover. So being able to do that and do that in a way where there's that great communication, you kind of cover it all. It might actually make you more efficient, though those visits can sometimes feel more time intensive.
And it does because it also helps with the mental health aspect because these visits are a labor of love. And we all know that they're very time intensive in the beginning, especially when people come to you. I mean, I'm in a situation, just for context, where a lot of the providers around my area don't do these medications, they don't prescribe them. And so we are referred into quite a bit. And by the time people get to us, there's a high degree of frustration and a lack of hope. And so that first visit tends to be one that gets a little heavy. And I think that when you do those things and level set in the beginning and instill hope and you inspire them and they know that you're there for them and that they've landed in the right clinic because we are like the inflammatory clinic, you see it in the room, it diffuse, right? It's like the shoulders drop a little bit, like just the anxiety. You feel it. It's palpable. And you do have to have, to your point, a well-trained team that supports because you can't do it all. And that's not, if you're trying to do it all, for me, it wouldn't be the best utilization of my time because if I'm spending it on things that I can train my team to do, that means I can impact another patient and I can see another person in another room. And so it's not, everyone has their own style, but I definitely have learned over the years how to fit like all of it in as best we can. And there's going to be outliers that just want your time, and we have to be aware of those. And those people are going to get a 20-minute visit maybe on the second one. If I'm like, I still think we've got some things to work through. And so it's also just assessing that of how do you utilize your time on that next follow up based upon how that first maybe initial visit went.
Well, Stephanie Simmerman, thank you so much for stopping by Skin Sync today at Rapids. Thanks for joining us.
Thanks for having me.
Thanks for tuning in to Skin Sync. Don't forget to subscribe to Skin Sync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.